The next speaker is going to deal with one of the big problem areas that we have in melanoma, and that is the fact that patients with advanced melanoma frequently develop brain metastases. Dr. Geoff Gibney is one of our newest oncologists on the staff at Moffitt, and he, along with Peter Forsyth, who's the head of the neuro-oncology program, have put together a special clinic just for looking at melanoma brain metastases, which we hope is really going to allow us to make some progress. Yeah?
Thank you, Dr. Sondak. So as Dr. Sondak was saying, I'm a medical oncologist in the Department of Cutaneous Oncology, and I, like Dr. Atkins, offer systemic therapies for patients with advanced melanoma. And melanoma brain metastases has been a major problem for the medical oncologist for quite some time. And we're now starting to make some progress in using systemic therapy. So the purpose of the talk today is really to give an overview of the problem that we're dealing with, general patient outcomes, how we've managed this in the past, and then the systemic therapies that we're using to now treat melanoma brain mets. And just to take a step back is, how does this happen? I get this question a lot in the clinic is, you know, my melanoma is under control or it was really small. Why did it show up in the brain? And it can really be explained mainly just the tumor cells really get into the bloodstream as they can see it at any time. And then they can circulate really through the cardiovascular system. So once the cells enter the bloodstream, whether it's from a tumor in the lung or in this example, it's in the breast tissue, the cells will circulate through the cardiovascular system, and most of them will die, but eventually they'll deposit into a small branch point like here, or down when the blood vessels get a little smaller, and then they can leave the blood supply in a process called extravasation, and then they can start growing, they can develop their own blood vessels called angiogenesis, or they could steal the blood supply away from other brain tissue. Eventually, if they're successful, they'll develop into a tumor, which is going to be a collection of cells, 500,000, a million cells before you're actually going to see it. And in this example, we see would be actually a very large tumor, but as an example. So if you look at the data historically, there's been a few publications where they say if you have metastatic melanoma, at some point during that time period, 44% to 75% of patients will eventually be diagnosed with a brain metastasis. Now, it could be something easily treatable, or it could be something much more serious. When I'm working with patients, I normally say, well, there's probably about somewhere in the range of 50% chance, and that's why we're going to do your MRI of the brain every so often to keep track of things. So patients who do develop melanoma brain met, they could have nausea, they could have headaches, they could actually present with a stroke. Seizures can happen, they're not as common. And of course, if it's a major event, whether it's a large tumor that's increasing the pressure in the brain or something that causes bleeding, it could actually be a life-threatening event and lead to death. Now, there is the question is, how often do people die from melanoma brain metastases is a hard thing to answer. There is one publication that has claimed that up to 54% of melanoma deaths are related to symptomatic brain mets. So if you were to do the math, there's about 9,500 deaths that unfortunately are expected to happen in the United States this year from melanoma. And if you multiply that out by 54%, we're going to see over 5,000 melanoma deaths, unfortunately related to brain metastasis. So this obviously is a major problem that we're trying to work through. So who are the patients at the highest risk? Who do we have to be most concerned about developing a melanoma brain met? Obviously, patients that have higher disease stage, so a stage 4 patient where it's widely spread throughout the body is at more risk than someone that had stage 2 disease, and Dr. Zager removed the tumor. Patients that have a very deep tumor are at higher risk. If the tumor has an ulcer to it, we know that is a higher risk feature that also can put patients at a higher risk for developing melanoma brain metastasis as a recurrence. Melanoma that arises on the head and neck surfaces or in the mucosa area, like in the mouth or the gastrointestinal system, can be at higher risk. A subtype of melanoma called nodular, where it's more of a bump rather than a flat lesion that grows. High growth rate, again, this would be sort of self-explanatory. We call it the mitotic index, basically how quickly the cells are turning over. Now, unfortunately, men are at a little higher risk for developing melanoma for one reason or another. The question we do get is, if I have BRAF mutant melanoma, or as Dr. Atkins is now talking about NRAS, which is also a hot topic, am I more likely to have a melanoma brain metastasis? The BRAF mutation or even the NRAS may make your melanoma a little more aggressive, but there's no clear data to say that you're at a higher risk for developing a brain met at this point. But this is sort of piecing together information that's available and hasn't been proven quite yet. So how do we manage patients that come into our clinic? So if you do develop, unfortunately, a brain metastasis, so if you look at the top example, somewhere between 1 and 4 lesions on this MRI, you can see that bright spot here, and this would be the parietal lobe area towards the occipital area. And you can see this little halo around it, that's some edema. Typically, patients would be started on steroids in that scenario. If they had a seizure, they might get anti-seizure medications. And then they're generally going to be referred for either surgery to a neurosurgeon where they will remove the tumor, or they'd be referred to radiation oncology where they would use a technique called stereotactic radiosurgery, basically delivering high-volume radiation to a very fine point to ablate the tissue rather than trying to treat the whole brain area. Now, when there's greater than 5 lesions, if you can see in the lower cross-section here of an MRI of the brain, you see these little hazy spots. This patient, unfortunately, was diagnosed with innumerable brain metastases, numbering much more than 5 lesions. It's not feasible to surgically remove them or to individually radiate every one. And even if you could, it's still likely that you're going to have more that show up in the future, some that are just too small to see at this point. So you're not really going to get ahead in controlling their disease. So what has been offered to many patients is a technique called whole brain radiotherapy, which is basically delivering a volume of radiation on a daily basis to the whole brain area in hopes that you're going to kill the cancer cells. That's given over generally 10 sessions and can add benefit, but typically is not going to get rid of all of the melanoma in the brain. So in terms of outcomes, if you use these therapies, what happens with the patients? How well do they do? As was discussed before, we use the term median, which is the halfway point on how patients do in the long term, whether it's survival or progression-free survival, meaning if the disease comes back. If you do nothing directly to the brain metastasis, if you just support the patient, give them therapy that isn't going to penetrate in the brain, unfortunately the prognosis is pretty bad, with the median somewhere around 2 months for survival for those patients. So most patients we would refer for some type of therapy. Commonly, what's been done in the past and in the scenario I just showed you where there's multiple lesions, we would offer whole brain radiotherapy, and we know that survival is going to be doubled for the patient as a group. Still not where we would want it to be, but at least patients are surviving longer. We know that surgery and stereotactic radiosurgery has better outcomes. Now, you also are taking the patients with less disease, so is it more the technique, or is it that the patient itself has a better prognosis from the beginning? But if we are able to offer those therapies, we know that the outcomes are much better, with survival as high as 10 months in the median. Stereotactic radiosurgery is at least 7.7 months, but that number is probably on the low side. And then there have been strategies to combine the two, and there may be a little bit of benefit of combining radiation with surgery, but it hasn't really been proven. We do, I would say, fairly often surgery with radiation to the surgical bed if a spot is likely to come back. So moving on to how can we do better? I'm a medical oncologist, Dr. Atkins, Dr. Weber, Dr. Kuchikar is both here. How can we use the therapies that we know can treat melanoma to help patients who develop melanoma brain metastases? Chemotherapy has been around for quite some time. There was discussion about DTIC or dacarbazine, another drug called temozolomide. There have been trials that have been used to treat active brain metastases, and there does look like there's some marginal benefit, but it clearly was not a home run. And a number of trials that we'll briefly talk about have been conducted. There has been some progress using immune therapy, and where I think there's a lot of progress has been in the targeted therapy. So we're going to talk a little bit about each one of these. So this is, I know, a very busy slide, but it's really to summarize a number of the trials with chemotherapy, combining chemotherapy with another drug to try and make it more effective, combining chemotherapy with whole brain radiation to see if it will improve the response. What I'd like you to focus here is in the red box is the response rate. So when patients who have active brain metastasis, you don't remove it or radiate it, you just put them on a systemic drug like chemotherapy, that the response rate has not been very impressive. Anywhere from 0% of patients having shrinkage in their melanoma brain met to as high as 12% of patients having some degree of shrinkage or even resolution in a few cases. So obviously these numbers are not very impressive, and we're certainly trying to do better for our patients. So immunotherapy has been looked at for treating active melanoma brain metastases. There's actually been reports historically looking back at the data for patients that were treated with interleukin-2, another technique called adoptive cell therapy, and there are patients that do have responses, but that hasn't been looked at going forward, so we don't know how often that is a good technique to offer to patients. But there have been trials where they've enrolled patients with active melanoma brain mets, and they've given them a systemic therapy rather than surgery or radiation. And the numbers are limited, so these percentages may be a little off because they weren't very large collections of patients. But you can see that the new drug, Ipilimumab, or Ipi, or Yervoy is the other name, you can see some tumor regression in patients that had de novo brain mets that weren't previously treated. At least 16% had some response, some shrinkage, and then 8% of patients had stabilization of those. If this is a recurrence of brain metastasis, the response rate seemed to be low. The 5% complete response in that group was actually only one patient, so you have to take that with a grain of salt. There was a European study where they tried to combine Ipilimumab with chemotherapy, a drug called photomustine, which we don't have access to in the U.S., but we do have very similar drugs in that class. We don't commonly use them, though, for melanoma. The reason they chose photomustine, they know it can penetrate into the brain wall, and there's some data combining chemotherapy with the immune therapy that might be helpful. So in this study, it was a very small number of patients, but they saw actually a very impressive response rate for active melanoma brain mets. 38% had complete shrinkage in their disease where you couldn't see it anymore on the MRI if this was their first time that they were diagnosed with the disease. They lumped their data a little different than other studies where they combine the number of patients that either had tumor shrinkage but not resolution or if it was stable. But they also had pretty good numbers where 23% and 43% of patients in the two groups had some benefit with active brain metastasis. So this is promising. There are some people interested in pursuing this further. It's not quite a strategy that we've adopted quite yet, though. So this is a patient of mine that I was working with who unfortunately developed melanoma brain metastasis during his Ipilimumab treatment. I wanted to use this as an example of how we're starting to combine some of these strategies. So he had metastatic disease, and before we started his immune therapy, there was a spot in the brain that we didn't know if it was a metastasis or not. We chose to follow it. And halfway through his treatment, he had another MRI of the brain. And unfortunately, it was pretty clear that he had now developed a lesion in the parietal cortex that was a melanoma brain metastasis, and then one down here in the frontal cortex right by the eye. These were asymptomatic, it didn't bother him, but we did want to treat them because they were clearly progressing during his systemic therapy. So we gave him radiation, stereotactic radiosurgery, and basically the high volume radiation over just those fine points where the tumors are. And we then completed out the 2 doses of Ipilimumab, and we repeated his MRI about a month later after completing that. And you can see on your left-hand side that those lesions completely disappeared. Now, that may have been partly the radiation, could have been the combination, could have been more the Ipilimumab. It's really hard to tease that out, but typically after you do radiation, those lesions will shrink and start to resolve, but this was very impressive. So there might have been some added benefit of doing the combination. I apologize, I don't not sure why that didn't want to come up. But that was just a diagram of the BRAF pathway, which Dr. Atkins just showed you. We know that half of melanoma has a BRAF mutation, and that if the melanoma has that BRAF mutation, it creates an active protein that drives the pathway in the cells, and we have the class of BRAF drugs that can block that pathway and have become used widespread and are very effective, at least in the short term, for controlling and shrinking disease. So as Dr. Atkins was saying, there's a number of these drugs being developed. Dabrafenib is the first FDA-approved drug. Dabrafenib is currently in development, has already gone through phase 3 study, and looks very similar in terms of activity, but those trials excluded patients with active melanoma brain mets. So no one was really sure if this would be a helpful strategy to offer patients that have active disease in the brain. So there has been a lot of interest in using these BRAF inhibitors in treating melanoma brain mets. And the largest collection of data is with the drug Dabrafenib, which is, as we were saying, very similar to Dabrafenib, the FDA-approved one. And what we can see here is that the drug is getting into the brain, and patients are having brain met responses that, although it's not clearing the disease, with only, well, I shouldn't say it's not clearing, but only 3% of patients who were on this study had complete resolution of their disease. There were 36% that had some shrinkage, and then another 42% where it didn't grow. So it was obviously keeping things under control for the majority of patients for that period of time. Now, if they had prior treatment, the numbers were similar, but not quite as good in terms of partial response and complete response. Unfortunately, this does not last forever. The DOR stands for duration of response. So the middle of the pack, it would only keep the disease under control for 4.7 months or 6.5 months. And the survival was under 8 months, which we know actually is better than the expected median survival for patients who never have seen a BRAF inhibitor. So we were very happy to see these results. And this is to give you a better idea. This is the forest plot. And basically, if it's measuring the tumor volume that's in the brain. And if you have a negative deflection, that means your disease was shrinking. If you got below that dotted line, we call that a partial response. If you get all the way down here, where you hit 100% regression, that's a complete response. Now, if you have a positive deflection, which is all the way over to the left, that is tumor growth. So as you can see, most patients are going to have some shrinkage in their disease in the brain, which is impressive. There really hasn't been any other drug with a waterfall plot. I think I call it a forest plot. There's a waterfall plot that looked like this. And what we call the transition point is way over there, which is impressive. That means most patients, 80%, are probably going to have some benefit with this drug. So I also wanted to bring another patient example. This is not one of mine, but was recently reported. A gentleman who had metastatic disease and presented to his oncologist after progressing through immunotherapy with Ipilimumab, and he had left-sided weakness. And they did an MRI of the brain, and unfortunately, in this figure A, they found this cystic structure that on figure B you see up here, there's some edema and the tumor there, and this was causing, this is in the right side, which left him with left-sided symptoms. They started him on steroids and Dabrafenib, and within 96 hours, I remember the report, his symptoms resolved. So he almost had paralysis on his left side, and they completely resolved. That might have been more the steroids than the drug, but either way it was very impressive. And you can see that there was some change after 37 days of Dabrafenib in the tumor, going from A and B down to C and D, where it's a little less prominent. There obviously is a little change here in the texture. That may be a little bit of blood product that started to fill it here. But clinically, he did much better. And when they were able to shrink this down, they made it more feasible to bring him to surgery. So they then resected this tumor. You can see here that they were able to remove most of it and successfully undergo resection of his disease. And then they put him back on the BRAF drug, and at least by the report, he's done very well with this approach. So you can see it's not very straightforward anymore, referring someone to a neurosurgeon, referring to a radiation oncologist, that systemic therapies are actively being integrated into the care of patients who develop melanoma brain metastases. So in conclusion, I just wanted to make 4 points, is that melanoma brain metastases account for the majority of the morbidity and mortality of melanoma patients, so it's a very important thing for us to address. A multidisciplinary approach is necessary for the management of melanoma brain metastasis patients. At Moffitt, as Dr. Sondak was talking about, we have the neuromelanoma program or neuromelanoma clinic, where a number of us are involved to discuss the care and integrate the services that we have for these patients. Targeted drug therapies like the BRAF inhibitors can be effective in treating melanoma brain mets, and I think are becoming used more often. And then further research is clearly needed to enhance the melanoma brain met response to BRAF inhibitors and to discover new targeted approaches for these patients. So thank you for your attention, and I don't know if we'll do questions.